Good evening, everyone. It's 7 o'clock. Let's start. Welcome to the 13th Masterclass of Jaipur Surgical Tutorial. And Jaipur Surgical Tutorial, or JST as we call it now, is an online surgical education portal that we started at the Mahatma Gandhi Medical College and Hospital almost 3 years ago. And the regular activities of JST are managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery and liver transplant at my institution. We conduct a weekly online educational activity every Saturday, 9 to 10 a.m. India time, where students present cases or operative surgery sessions, which are moderated by faculty. And last year, we started these master classes, which are held once in a month. It used to be last Thursday and Friday of the month, 7 to 9 p.m. both days. But very recently, IASG has started another academic activity along with the National Cancer Grid, which is on Friday evening, same time, 7 to 9. So we have now shifted the master classes to Wednesday and Thursday so that students can attend both the online activities. And this is the 13th master class, second part. Yesterday we did the first part. So today's session, I've requested our former fellow from SGPGI and now senior consultant at Pace Hospital in Hyderabad, Dr. Ravula Phani Krishna. He will be moderating the session. Phani, maybe we can request Ajay to start. So over to you. Please moderate.
Yeah, sure. So the first speech, first talk would be by Ajay. Ajay is, of course, we worked with him in Sanjay Gandhi, and now he's heading a very large and a very busy unit in Jaipur. I think he's going to talk about when to feed in CSTM, in Whipples, post Whipples, and it's one of the big contentious issues. There's a lot of controversy, a lot of anxiety from the surgeons and the patients, and there's a lot of data he has to go through. Ajay, thank you. You can take over from here, Ajay.
Thanks. I agree with you that this is a very difficult topic to handle and very close to my heart. That is feeding after a pancreatic duodenectomy. Yes, PD is very close. We have been doing a lot of Whipples in last so many years, and we have developed many techniques. But what is important for me to introduce is, so definitely PD is the treatment of choice. The main important thing related to feed is the delayed gastric emptying, which is still being documented to the level of 20 to 40%. But ERAS protocols have shown some promising results with PD also. So now how I will cover today's session is, first I will take up the traditional methods and the relevant anatomy. What is early recovery? What are the refeeding methods? How does the post-op complications affect the feeding? And how does the reconstruction affect the refeeding? And pending, how are we justified into it, which we can go for discussion subsequently. So traditionally, we know the patient has a Ryle's tube in position. The feeding tubes are, as a ritual, they've been placed for years. Feeding started in feeding jejunostomy, say sometime when I remember was on day 4, day 5. First, the saline feed was being given as a clear water, a clear liquid for a day, and then half strength feed and in low volume over next 24 hours, then started gradually increasing the FJ feed in next 24 hours. And once the patient is tolerating, that is the time that we feel that now we can give a large volume of feed by his feeding jejunostomy also. In case the feeding jejunostomy was not tolerated, the patient was again put on NPO, given IV support, or then if he's affordable, could be put on TPN. And if the patient was unable to tolerate in few more feeding jejunostomy trials in coming few days, then TPN was the option left. Some surgeons, we often know that since Dr. Kapoor is there and he was very fond of NJ tube and Ryle's tube both at the same time. This was also a very common area which was being used, both Ryle's tube and NJ. And NJ to feed was same as protocol as Ryle's tube, that started after few days, 4th day, 5th day, and then gradually increase it, first half strength, full strength, not like a Ryle's tube feed, which was started as a large volume feed on day 1. So maybe I can show this. This is the first article which I would like to refer, that the feeding jejunostomy in pancreatic patient. Is it important? So most, I think in last discussions also we have seen, yes, this is an important thing, that feeding jejunostomy most of the surgeons will prefer to have. So why feeding jejunostomy is important is because definitely the patients who are undergoing PD can have major complications, and at that time they need a major nutritional support. So FJ can prevent from a long-term TPN. So FJ is one thing that is warranted and has been traditionally been put by most of the centers worldwide and even in the country. And yes, it is now, as I go on the discussion, we will have more contradictory remarks, more discussions, and more things out of it now, out of the box that we have to think now to develop it. What has happened in last so many years is the changes were brought out after the eras in the various abdominal surgeries. Enhanced recovery protocols originally was for any bowel anastomosis, and the feeding was started in a day or after weeks, which was earlier. Now it has been started early. The preoperative fasting, which was used to be at least for overnight or a day prior to the surgery, has now cut down to 6 hours. Post-operative bed rest has restricted. They have started ambulation as early as possible. And these ERAS protocols have been studied mainly, which was started in colon and if you see for luminal surgeries. Initially, maybe for hernias and other things, they were being tried, but colon was the first data which has come for ERAS effective protocols. Many areas of debate in in early recovery protocols was an acute abdomen. Should we start? That was a lot of controversy, but now people have started in acute abdomen as well. As soon as the patient is settled, esophageal and gastric anastomosis, again there was a lot of controversy and discussions into it. But it was definitely tried for lap choles. Immediately day one, we start feeding biliary surgeries, for perianal surgeries, for the small liver surgeries, hernia surgeries. And this was around till 2010, this was being developed worldwide. Now, why PD is different and it has not been worked up so much, even in ERAS protocol at so much time? Possibly, the thought process was there's a post-op DG, which we are always delayed gastric emptying. We are worried. PJ leaks, which we are worrying. And post PD, they can be major bleed complication, which again worries us. And complications difficult to tackle and long time to get normal after PD. It was unlike in other luminal surgeries where you can re-explore, make a stoma. PD did not have those options. So a complication meant a long duration recovery time, difficult recovery, long duration of antibiotics, long duration of IV fluids. So possibly that is the reason that people have been suspicious of or doing early recovery protocols in this. Adding on to this more is that the patients have been, for PD patients have been said that they have nutritional deficiencies, they have a poor general conditions, they have poor wound healing tendency, and they have been without enteral feeding for a long time. But I think these things will hold on for, I think, CA colon, yes, they are also nutritional deficient patients. Poor general conditions, they bleed more, so they are all in poor conditions. They also have poor healing tendencies as with any other malignancies. So I think this is not, the nutrition does not hold only with the periampullary or head which requires PD, but for most of the other diseases as well, including small bowel or even in tuberculosis of intestine, which we have a small bowel resection. So how the post-op nutrition after PD has been thought about, what are the modes? Definitely one mode which is controversial is still oral feeding, nasojejunal, as I have said, and feeding jejunostomy and TPN. These three have been the standard over these years. Feeding routes, what I have mentioned, that it has there's an article which shows that oral feeding, enteral nutrition, either by nasojejunostomy, gastrojejunostomy, or a jejunostomy tube, or a TPN. And in the last, you can see an early oral diet may be considered a preferred route of feeding strategy after PD. So enteral feeding is more important, and he says oral. So we will come to this discussion in the coming slides. Early oral feeding after PD. So I'm just going to the literature first before I go on to the discussions. That recent article 22, early oral feeding, you can see in the conclusion currently available evidence shows that early oral feeding after PD is not associated with increased risk of delayed gastric emptying, does not exacerbate post-operative pancreatic fistula, and appear to restore the length of stay. Now, I would like to just halt at this slide because though this publication is 22, if I go back to the literature, 2010 to 2014-16, that was the era when there have been a lot of discussion that enteral feeding increases the fistula rate. Enteral feeding, oral feeding increases the DG. Enteral feeding increases the complication rate. So after 2016, there have been a gradual decrease in the numbers of the complications, which have shown that enteral feeding does not increase the complication rate. And these are the recent data. So PD is associated with, it is not associated with DG, again with postoperative pancreatic fistula. Similar article, you can see the various articles which have used it from Netherlands, Korea, Belgium, China, where they have started early oral feeding. And most of the articles have shown that it does not increase the complication rate. It can be well tolerated. Similarly, the DG, one of the articles in this which has shown that early DG, that DG may be increased. That was an old article. And in 2021, it is again shown, one of the article which was a small number of patients, again shows that there is an increased risk of fistula. But I think majority of other articles goes in favor that early oral feeding does not increase the complications. Operate the empirical therapy, what we can use TPN, but you need, this is a meta-analysis which has shown that post-operative pancreatic fistula is not increased. The support has to be required, and best route is the enteral. Early enteral versus oral nutrition after PD. This is a presently ongoing trial which has now on the midway, but its present day study which was presented last has shown that it has very positive results of early feeding, early oral feeding, not early feeding, early oral feeding following a pancreatic duodenectomy. So after all this literature, we have thousands of literature which have been hovering around it, and most of them are now inclined towards early feeding. Do we agree that early feeding does not affect the PJ leak? Early feeding has no harmful effects on DG, and early feeding gives us no loss. If we agree to this concept after this literature, I think that is the time to proceed and think, should we start early feeding? So the first thing is the concept that does it increase complication? No. So presently, let us now come to the halt that at least the feeding does not increase the complication rate. That is the literature has shown us. Now surgeries, we will be saying, say, now there are main three areas, that is classical PD or a pylorus preserving or a pylorus resecting, which we do. Now it depends also on PJ technique and whether to do a FJ or not to do FJ. I'm not going to PJ technique because it has been vastly discussed in this in these sessions, but I'll be coming mainly to the classical PD, in which we know that the antrum is resected and the stomach is anastomosed to the jejunal loop, which after PJ and HJ comes into the gastrojejunostomy. This is a classical PPPD, in which just wanted to show these two films just to show the size of the anastomosis, which will be coming in my coming presentations. The size of anastomosis in PPPD or pylorus resecting pancreatic duodenectomy and a classical Whipple's is different. The size of anastomosis is very important over here. This is one of my baseline line diagram which I have chosen, which shows a PD, a PJ, a HJ, and then subsequently a gastrojejunostomy. We know that the stoma size, I have written those 6 to 10 centimeters, but most of the time it will be something around say 15 or 20 centimeters of gastrojejunostomy, which is made following a PD between the stomach and the jejunal loop. What happens with this anastomosis normally? Let's come to it. What happens is the bile which is coming into the afferent limb has a wide area to go into the stomach and cause a lot of antral gastritis. This is the concept on which we work presently. So I'm just sharing my concept and the fact that we feel, as compared to the anastomosis, which rather than making a full wide anastomosis, if you make a slightly smaller size anastomosis, there's a preferential flow which goes into the afferent limb to efferent limb rather than going into the stomach. We know there is no pylorus, but decreasing the size of the stoma definitely decreases the reflux rate into it. Second thing, the peristalsis in the stomach. Again, coming to the same line diagram, the peristalsis in the stomach, that is from the fundus into the body and naturally goes towards the lesser curvature, towards the pylorus. It does not come onto the greater curvature side. Peristalsis in the afferent limb goes towards the stomach, and so there is a vice versa combination of the peristaltic action, which is we call as not an isoperistaltic, but it is a reverse peristaltic movement, and we have a wide anastomosis. So very high chances that this bile may reflux into it, and this peristalsis in the stomach may not help empty the stomach into the jejunal limb. This is the area where it should have emptied, and this is not helping us out in emptying the stomach. Rather, the peristalsis in the stomach, even if you do an anastomosis near the greater curvature side, it is still going towards the lesser curvature, and toward the pyloric area. Even if the anastomosis is onto the greater curvature, which is a small luminal anastomosis, the peristalsis in the afferent limb will have decreased reflex, but it is still not emptying, helping us to empty the stomach. Now, if we see, I will not be talking much about PPD because PPPD is not not we have been doing, and PPPD had shown some increase in the incidence of DG maybe, and then subsequent literature says that it does not. But I'll be restricting my discussion subsequently onto the pylorus resecting pancreaticoduodenectomy, where the stoma size, again we say it is around 3 centimeter size stoma. We resect it just proximal to the pylorus, the stomach, and then do an anastomosis. So if we see for PRPD, how does it work is that the bile flow is, this stoma size is small, bile flow is in the peristaltic direction. There is less likely to have reflux, to have antral gastritis, which may be a contributory factor for irritating the stomach. The peristalsis in the stomach is in a normal line, which is the normal human being. Normally it goes towards the pylorus, so it would empty towards the pyloric side where we have an anastomosis. So it is more likely to have a better emptying as compared to the other anastomosis which we have discussed in classical Whipple's pancreaticoduodenectomy. This anastomosis is still anti-peristaltic because the two peristalses are working in either in reverse direction. We may make it isoperistaltic, but we have found that isoperistaltic and anti-peristaltic anastomosis at this place does not make much difference in the gastric emptying, and both of them had same results in our hands. So now next is, after this anastomosis, is impact of an anticolic versus transmesocolic reconstruction. A recent article in which they have shown that transmesocolic reconstruction may be superior to anticolic reconstruction in minimizing the development of severity of DGE. So what do they mean by transmesocolic excision? Is this is what they have shown in their line diagrams. This is a retrocolic anastomosis that they are doing a GJ proximal to the proximal when it is coming out from the mesentery. This is normally an anticolic gastrojejunostomy, and this is a transmesocolic gastrojejunostomy, and we normally prefer a transmesocolic gastrojejunostomy at our place. Now, what is the basis and why do we think so is the problematic technique, or it can be organ related. It is technique related or organ related. The problems, that is, one is PJ leak, which can be because of small PD or because of the soft pancreas. HJ leak because of an undilated duct or a difficult anastomosis. Both PJ and HJ leak and subsequently bleed, and these are actually, I suppose, to cause DGE, decreased emptying. But I have a feel which I'm still not able to substantiate anywhere, because these are all what we have seen. But I still have a feel that following PD, there is always some inflammation in the pancreas, and there's some inflammation in the pancreas is in the area of the entire body and tail of the pancreas, which is left, and that affects the stomach motility because of the inflammation over there. So basically the principle is GJ and stomach should be away from the site of complications in pancreaticoduodenectomy. Now, if we see that what he has done is retrocolic, the GJ still lies close to the complication site, that is the PJ and the HJ site. If we see that gastrojejunostomy, if it is made anticolic, the anticolic site, though it is away, but it can still retract. The stomach normally, when it contracts, it may retract the GJ site into the proximal area, where it can still come close to the site of PJ anastomosis, which may have inflammation, which may have leak, which may have decreased the gastric emptying in the remnant of the stomach. But if we see GJ, which is coming through the transmesocolic, we usually fix it to the mesocolic area, and this anastomosis is infracolic, which is away from the supracolic area, which has all the major anastomosis, that the PJ and HJ, and the complication of the PJ or the complication of the HJ and the inflammation in the pancreas all remain away from our GJ side. So possibly this empties better. That is our feeling. What we have done was presented by my colleague, Dr. Vinay Mehla, who had presented it in Japanese Surgical Society last year. And I'm exactly just copying his slide, which he had presented. This is a prospective evaluation of a protocol of a conventional oral feeding and to assess its effects on post-operative outcomes. What we have done is, this is the early oral feeding at that time in 26 patients, conventional oral feeding in 40 patients. And there was no FJ used in these patients, though FJ was placed in the conventional feeding method. And according to need, TPN was required. Here, we did not give TPN to any of these patients. Oral feeding was started 6 hours after the surgery, and conventional method we started to do it early with a FJ or a nasojejunal feed. And day 2 we used to start SIPs, and then day 3 oral liquid diet. Here we used to get a rice tube removed a bit late, which we can remove early, but because of my fear that rice tube reinsertion may cause problem, that is my philosophy. So I felt that we will remove it once the patient takes oral diet normally, and we used to give a complete diet at that time on day 3, and then the IV fluids were stopped by day 3, and day 4 onwards the patient is on normal diet. Nasogastric tube we used to remove on day 1, as I have already said, and most of the patients have got discharged by day 5 if no major complication was there. So results, we had a comparable data between the two groups, and we have found that days to start oral liquids, an early oral feeding group 26 patients was on day 0, soft diet on day 0 as compared to 3.8 days in the conventional feeding. The oral solid diet on day 3 versus day 7. Days for nasogastric removal was 1.3 to 3.9 days, and days for the first stool passage was earlier after we started early oral feeding as compared to conventional feeding. And the days to stop the intravenous fluid, definitely it was earlier if we start the early oral feeding. And the post-operative hospital stay, as all the data says, is shorter when you start an early oral feeding. So in this article, we have concluded that the early oral feeding after PD is feasible, it is safe, and reduces the hospitalization. And this is the slide I did not want to change because my colleague Dr. Vinay had used this in JSS. So I still wanted to continue the same slide. And with that, I would like to conclude my session. But I would be happy if there's some discussion or any questions, because I know this is a thought-provoking idea with a lot of data support now onto early feeding. So maybe if any of the questions, Phani and Dr. Kapoor sir, maybe we can discuss on that.
Phani, please.
Yeah, Ajay, I think it was an excellent talk. I think one thing you established very clearly is that early enteral feeding does no harm. I mean, it's definitely something which should be universally practiced. And I think the work you've done on PRPD, pylorus resecting pancreatitis, that shows, and the literature, the talk on early versus late oral feeding shows that you've done a lot of work on this. You've really put in a lot of work on this in your unit. In fact, this trans mesocolic approach, it's not just you. It's been other people also thought about it. In fact, when we were in Asian Institute, I don't know if any of Pradeep sir or anybody is there. We used to call it the infracolic approach. The infracolic approach. So there's anticolic, retrocolic, and the infracolic. To the left of the middle colic, bring the stomach out and keep it away from all the area of where all this, the inflammation is occurring. Couple of things. One is, I mean, I think you just focused on that part alone. In terms of the DG techniques, all that, I thought you'll be covering those also, but you've just focused on this. But it's been a very focused talk. One thing is, not all patients of this thing are DG. One people, we assume sometimes that if the right aspirate is high, we assume that it's DG. Sometimes they're actually due to technical adhesive obstructions beyond it, FJ Kings and all that. We've had a couple of experiences like that. And this thing of whether we should do an FJ at all or not do an FJ, I'd like to know your views on it, because after later on, after Whipple's, trying to put an NJ is actually, it's a problem. It keeps calling back and all that. So have you completely given up doing FJs, or is it like, do you categorize them to high risk and low risk patients for DG and then do that?
I agree, Phani. What you're saying is very correct. Most of the centers do an FJ. We used to do an FJ long back, but fortunately, during my experience at SMS, we had a very vast experience of PD at that point in time, where we felt that putting an FJ used to help in some of the patients which had complications. Now, you have to be very sure that you don't have a PJ leak and you don't have a complication following a PD. If your complication rate is decreasing, then your FJ is not going to help you. That is for sure. FJ is going to help you when you have a complication. So first target is not on DGE. First target is on decreasing the complication rate. And I think I always tell to Dr. Kapoor that Blumgart should be given a Nobel Prize for his technique of doing a PJ anastomosis, after which worldwide the data has drastically changed on PJ leak. it is not only with us, but it is worldwide. So maybe, but we are very happy that we don't have a significant PG leak. Though now we recently had 1 or 2 patients which had a small leak and then subsequent complications. But most of the patients in last so many years, at least in our hands, maybe in experienced hands, I would say, they don't have a leak. So if the patient does not have a leak, doing a FJ may not be of much help. So if first target is achieving you may do a FJ till the time you achieve that you are PJ and HJ does not cause a complication. Once you have achieved that, with this we achieved somewhere around 2017, I feel 2017-18 was the time when I stopped FJ for time being, and I did around say 20 PJ without FJ, and I had a complication in one of the patients. I again restarted putting FJs at that point in time. Then after coming to Mahatma Gandhi in 2019, we initially used to put for 1 or 2 or 5 patients, and then subsequently we stopped it because now that by that time I was confident that it will not happen. So now since then till date, we have not put an FG. So maybe it is sometimes, yes, it may cause an harm, but it is so rare that I don't feel that it is much utilized.
The transmesocolic GJ, which Ajay described, I am reminded of the time when we used to do a lot of surgery for peptic ulcer. They got me and GJ. And that time I remember, and I think for Carson, I don't know whether it is still mentioned, used to mention that you may do the GJ by bringing the jejunum up through the transmesocolic window. But once you have done the anastomosis, you need to pull the stomach down and fix it to that window so that finally the anastomosis lies in the inframesocolic compartment. So just an
I think Farquharson still mentions the same lines. Farquharson, I still recommend to my junior residents and colleagues, you should go through Farquharson because Farquharson is conceptually a very strong book. It may not be technically. The Rob Smith is technically very good book, but Farquharson is conceptually very good book. So following Farquharson is better to develop baseline concepts. So I agree. And second thing, funny what you told is transmesocolic window. This is when we were passing out from SGPJ 2006. This was the first article which had come from the transmesocolic from Japan, and this we were going through when we were giving the exam. And I realized that this should be beneficial in coming days. And from then we started developing it, and I realized that definitely it works. Possibly you must have also seen that it works well.
Yes, yes. And in fact, ours was a DNB thesis, it was an RCT. So in fact, we documented by doing a HIDA scan, a gastric emptying scan on day 7, and documented that in this infracolic group, it is actually, the emptying is better.
So funny, to complete my presentation, I would like to add that now we are also, since this has not been accepted so many times, people don't agree to what we say. So Dr. Kapoor suggested to have a documentary evidence. So now we have started that scan now to document that the stomach is emptying into the jejunum in 100% of the patients. So to document that, now we are doing a scan, and we've already got the permission of that
isotope gastric emptying.
Isotope gastric emptying study now. So we'll be doing this in the coming years now. What I think most important thing is this anastomosis being small in size, the peristaltis being in the normal direction, and the peristalsis of afferent limb not letting most of the things go. Though still bile will go into the stomach because we don't have a pylorus over there, but it works well. So that is my assumption, and maybe it is working because of that. I don't know, but there might be something else as well. And keeping it away from PJ and HJ. Now, recently in my maybe 2 days back or 3 days back, I was telling on my rounds that this PJ anastomosis always leaks in the anterior to the PJ. If it leaks posterior to the PJ, it will come out through the drain. But anterior to the PJ, it is always harmful. And that is the reason earlier, if you remember, we used to put one drain at HJ and one drain at PJ. Now we put one drain at PJ on the right side and one drain on the PJ from the left side. This left drain, I feel, is always more important because this will secrete something or the other. And this is the one which will have sometimes higher mileage. The right drain will not have any volume. Right drain may not have any mileage, but left drain will always have. But looking into the data retrospectively, my resident told, sir, what you are saying is both of them have an equal value. But I still feel every day we see the patient and the left drain is always having a relatively higher mileage as compared to right. So left side, PJ anastomosis leak is always onto the anterior side. And that is a possible reason which explains that the collection over here or an inflammation over here leads to a decreased emptying of the stomach. So this has to be taken care of much better.
Ajay sir, what is the instance of delayed gastric emptying in your series?
After a long time, we have had one now, after many years.
Because one of the most important thing in Whipple surgery that we are doing around 60 Whipples a year. Most important limitations in Whipple surgery, I think, is delayed gastric emptying. It's still in best of the center is 25 to 30%. And if you're starting, and this type of DG generally occurs third, fourth day or fifth day when you start oral feedings. So when you start oral feeding day one, how you predict that it is not going to be a delayed gastric emptying or not going to be a PJ leak? Because finally outcome is not important to how early you start oral feed. It is more important what is the rate of your delayed gastric emptying, which may not be any related to PJ leak or any complications of pancreatic duodenectomy. Still, it is 25 to 30%. Then how can you justify to start oral feed in day one and knowing that delayed gastric emptying can happen in 25%, means 1 in 5 patients of pancreatic duodenectomy?
Yes, Utpal, that is definitely a controversial issue. That is definitely a point of discussion. That is definitely a very much vibrant discussion between me and Phani so many times, between Pari and me so many times, and with other colleagues. But I still feel either our patients are different, I don't know. But we have not seen a DG. When Dr. Kapoor joined, you can ask him. It was very difficult for him to accept this fact that there is no DG. But now everybody is doing, and there's hardly any DG. So there's a factual data. There's a factual data which was actually compared between the two groups, age matched groups and everything. And after that, you can see that there's hardly any patient which is having a DG. So I feel that this is my feeling. Either we have different patients or there's something different. This is the details of the trick which I have told you, that what we do in our anastomosis is a mesocolic anastomosis. We do only a pre-pyloric resection always. This is the classical anastomosis we do. We take care of PJ leak is hardly there and nowadays. So I don't know, but DG doesn't happen.
So Dr. Ajay, the data you are showing that in 26 patients you have started in early internal feeding. This data may be biased. Maybe some good patients with hard pancreas, with the large duct, which has a lesser chance of pancreatic leak. So you have started in this subset of patient early oral feeding, and you have get good results. And that conventional feeding in 40 patients, maybe that bad type of pancreas, like soft pancreas, undilated duct, there are high chances of PJ leak. So you have started in that patient conventional. Until unless you do randomized control type, you cannot say conclusively that this is actually you cannot make conclusion based on this data.
Let me no, I'm not telling you to make a conclusion based on the data, but let me come to this fact, this feeling, this status. What you are saying is that these two groups are different. No, these two groups were same. Problem is, this is what my colleagues used to do when I joined. They were not ready they were not convinced for doing a early oral feeding. And so this is their data. This is what I was doing. Subsequently, we all agreed. And subsequently, now everybody is doing. Now, 100% of our patients undergo, we don't do any patient to start feeding on a later time. We start feeding on 100% patients on day one, rather on day zero now. So it is irrespective of the type. Yes, definitely PJ leak is very less, which I agree. And maybe in coming years, if we have some complications with PG or some collection or DG, yes, we may have to change, but till now, and this is only the part, this is only the tip of the iceberg which I am showing, because the data which I have was enormous in numbers before coming to Mahatma Gandhi, and actually that was the one which had made me to feel on this direction. So that, this is just the tip that you are seeing. This is the slides which was used for presenting in the Japanese Surgical Society conference. This is only a small spectrum which we were showing, comparing the two groups. But if you see the entire group, if you see, if I show you the data which I was writing was on more than 650 patients in 7 years, which out of which almost 200 were having early feeding. That was a huge data which I feel. Which I was writing, but by that time, multiple other publications, and then subsequently that data, I was not having that complete data when I was working at SMS and in the other private centers. It was only after coming to MGH that we started having a collaborated data now. So maybe that is a limitation of it. because of the small numbers, yes, you may agree to it. You may say that this looks like a small number, but this is only the tip of the iceberg that you are seeing.
Before I ask Professor T.D. Yadav to give his opinion, this thing, Utpal, we are looking at two separate issues here. One is early oral feeding, then other is incidence of DGE. There is clear-cut data, level 1 evidence, quality evidence in literature, so that showing that early oral feeding does not have any harm. Even if you don't feed orally, DG is going to occur because the saliva, gastric secretions, pancreatic, biliary secretions, 4-5 liters, it's handling. The early oral feeding is not a contentious issue. I mean, whether this Ajay's technique delays gastric emptying, what are the best techniques, what is the difference, that you can debate. But I think even especially in PD, and in fact most after gastrectomy, after bariatric and acute pancreatitis, there is clear-cut literature even in PD that early enteral feeding is not the cause of PJ leak or delayed gastric emptying. Maybe we are a bit hesitant that okay, we feed early, there's delayed entry starting on third day or something, the stomach is going to get hugely distended. But that I don't think anywhere it's been shown that early enteral feeding is actually the etiology behind delayed gastric emptying. Professor Yadav, you've been quiet. I'm sure you must. I mean, over the years, you must have a huge experience of this and your own thought process about this. Could you share your thoughts?
No, but thank you, Phani. But the question is, we are discussing it with Dr. Ajay earlier also. I think one or two points are important. One is that when he showed the picture of total end of the stomach being taken into, I think that practice was. I don't think anybody will do, because all the modifications and most commonly used modification, child modification, which uses part of the towards the greater curvature to maintain the same type of flow and closing the upper part of the stomach, that usually even after gastrectomy, even after all those things. The thing is that Ajay has shown his data, quite amazing data, that the pancreatic leak is so less, and those things are very important. We know that nowadays you can put a tube. Recently, I was doing one pancreatic me, so I put a, because there was a most probably acute pancreatitis, and I was not very happy. Patient little bit of heavy, so we put a anastomotic tube. And if this patient is private ward, so I thought if there is a problem, TPN can be given. So somebody is seeing it, and if then only he can believe it. And our as a department, our numbers are huge. But you see, we are crossing about 75 per year. But the question, not me alone, all the 3-4 people who are working in the department. But we are analyzing, we are realizing that PJ leak is not in our hand. Most of whatever good anastomosis you do, sometimes a little bit of early pancreatic leak might convert into established pancreatic fistula, might heal. These are the some issues, but as you said, the transmesoquilic part, which is has been described, that is one small anastomosis. And orally, day one, I have not yet started, and we try to put a rice tube, but don't try to aspirate. This is also true that food is a good agent to start peristalsis. Yeah, any oral diet. And in a small bowel anastomosis, our agent used to start orally same day, because we pushed all these things, colonic anastomosis, all those. But here in pancreas anastomosis, there are some factors that Dr. Utpal was trying to highlight, that if pancreas is duct is dilated, if pancreas is firm, and you can do a good anastomosis on the table, it seems you are very sure that it is not going to leak. HJ usually is a consequence of PJ leak, usually doesn't leak if you are very careful in doing that. But in a soft pancreas where you are small duct and lots of fat around, all the factors which are responsible for the PJ leak are there. So I think we can take this as a one of the inspiring thing by Ajay, and some modification can be done, but I am still not sure whether a day one we can start orally and day 5 can be discharged. So it depends on the surgeon to surgeon. This would be my thought process.
I would like to add to what Dr. TD was said. One thing, actually, there's a lot of data now. One thing is that however happy sometimes we were with the PJ anastomosis, however good the pancreas was, it would leak. And sometimes the pancreas was so bad in the initial days and still it will not leak. So I don't know what the reason was at that point in time. Second thing is, now while I was going through the data on PJ leak with feeding, there's a lot of data now which says that this feeding decreases the leak rate. So I don't know. I did not put that into the slides now because that will add one more controversy to it. It says that once you have a started oral feeding, so there is a jejunal stimulation. That jejunal stimulation increases the peristalsis in the jejunum, which has a siphoning action on the pancreatic juice. To rather than going into the leak site, it goes into the jejunal loop. So there were some articles. So I don't want to put all those controversies, but yes, enteral feeding can be started, and maybe if somebody can try, it will add to our experience as well.
Only thing is, I have suggested, Ajay, that we should document this by doing these isotope gastric emptying studies where we can show that early oral feeding stimulates the stomach and may be decreasing the risk of DG. Ashwini is there. Ashwini wants to make any comment on Ajay's presentation.
Good evening, sir.
Good evening. Anything? What is your feeding practice?
Sir, even though our numbers are not great, we do about 10 to 15 Whipples per year. And we don't do any feeding gymnostomy. We keep a NJ tube and we don't even keep any nasogastric tube. And we start on day one feeding.
But that is NJ feeding.
NJ feeding, sir. No oral, NJ feeding. Oral, day 3, day 4.
Okay. The conventional.
Day 3, day. Yes,
conventional
sir.
protocol. Yeah.
Yes, sir. Yes, sir.
Okay.
Funny, now we have tubes which can be inserted into the stomach, which have a double lumen and can be used for both gastric decompression. So that can be used for as
That
a
can be
separate
used.
tube
Yes,
itself.
yes.
FJ, if you, my personal feeling is FJ is better if you want to put rather than 2 tubes. But Kapoor sir is always happy putting a nasojejunal tube. And I still remember during SGPGI times we used to have a controversy whether FJ versus 2 tubes. And I remember Dr. Rajneesh once telling that after their rounds on Saturday they used to have a major round, and on Friday PD was done. And where is the FJ? So that resident had actually forgotten to take the FJ out from the abdomen, and he has put a FJ tube into the jejunal loop and forgot to take it out. So some things or the other. And once there was a contact, Sujay told that there were 2 tubes and they got knotted into the stomach. So some of these complications can happen, though they are rare. And I think oral feeding has no much complications. If only thing is it is difficult for us to digest.
We've used the Freca tube quite a bit. I mean, yeah, it's good. This thing. I mean,
For a gastrojejunostomy, what do you use, Phani? Do you use a tube?
I mean, so it's been highly selective, man. That's like a long discussion. We select, I think 80% of the peoples, we don't do a feeding jejunostomy. A small group of high risk patients like soft.